My name is Janine Stiene, and I'm the owner and operator of Long Island Speech and Myofunctional Therapy.
And I'm Toniann Antoniato, speech-language pathologist, certified lactation counselor, and SLP director for the Suffolk Center for Speech.
We welcome you all to our first episode of Talk the Talk, where Toniann and I, the masters of myofunctional therapy, interview physicians and dentists as well as other providers on Long Island so we can learn how their services can benefit your child's speech and language development and complement the therapy that they are receiving. Today we are joined by Dr. Siegel, world-renowned oral surgeon who's been devoted the last 20 years of his treatment to the issues of related to tethered oral tissues. He's board certified with both dual degrees in MD and DDS and operates his locations out of both Huntington, New York and Manhattan, New York. He has performed over 30,000 tethered oral tissues surgical procedures to date. We've been sending our patients to him for years and have just the utmost confidence in his abilities. Thank you so much for joining us today. We really appreciate it. We're just going to pick your brain a little bit. Our first question for you is, when evaluating a patient for the first time, are you assessing for all different types of tethered oral tissues?
Yeah, I mean, basically, first, thank you guys for hosting this and having me here. It's always, humbling and an honor and a privilege. And I certainly love working with your whole team. You have an amazing team.
Thank you.
It's great to work as a team with you guys to get the best results. But yeah, when we look at kids and adults, we see all ages from newborn up on to elderly patients that have, potential restrictions in the mouth. So the most common that people talk about is what we call tongue tie, but we kind of group these whole little, areas of what we call restrictions inside the mouth as tethered oral tissues, or the acronym is TOTS, T-O-T-S. But we assess the full mouth, oral cavity and how it affects function. Basically that's kind of the short answer, but yeah,
okay.
Multiple areas.
Okay.
How might your evaluation and recommendations of a tongue tie differ from that of a pediatric dentist, pediatrician, ENT, or any other medical professional?
Well, I think the biggest thing, and it's not just, depending on the specialty, I think it's having an understanding about, what is actually going on and how these tethers or restrictions or ties, as they're called, affect function. How are they affecting feeding? Are they affecting speech? Are they affecting breathing? Are they affecting dental or oral facial growth and development? And we find that, depending on the practitioner's specialty or understanding or education about this, they often get missed, or what we say dismissed, and kind of, pushed off as saying, we find that, many pediatricians, if you're dealing with younger children or even babies, the biggest focus tends to be on weight gain. And that's we hear that kind of across the board. If your child's gaining weight, or they'll say, if you can stick your tongue out, you're fine. And
yes.
There's no tie and you just go along your way. So sometimes, you'll get a referral from, to a pediatrician, or a family will go from the speech therapist or the feeding therapist to the pediatrician asking those questions. And we see that they're basically dismissed very quickly. And we find that we work with many pediatricians who do have a deeper understanding about these things, and we'll make a referral to a specialist who deals with this, such as myself or some other docs. So some pediatric dentists understand this and are very good at picking this stuff. Some ENTs are, but as a generalization, and same with oral surgeons, it's not part of our education. I went to both medical school and dental school, and I got zero education on this stuff. You're shown maybe one slide on it, and saying that it doesn't really impact anything. And there's been a lot of research in the past several years looking at this stuff and the impacts on function, growth, and development. So
yes, we definitely see more and more research coming out, more and more people supporting lingual frenectomies and becoming more knowledgeable about them.
Right.
How would you define a tongue tie if you were defining it for a layperson?
So what we talk about, a tongue tie is, we all talk about the little strings in our mouth, so if I'm going to, look and show you, it's the when I'm lifting up my tongue, I don't know if you can see, but there's a little string under there. So
Yep.
we want to see, is that string short? Is it tight? Is it restricting the, function? It's not just about how it looks, but it's how, it's affecting function and the symptoms. So a tie or a tongue tie is basically a shortened piece or remnant of, we all have these things called frenulums that develop in utero in the first trimester. And in some instances, they don't dissolve away completely. And you're left with these restricting, membranes or areas that are, thickened or tight. And you can have them under the tongue, you can have the lip, you can have the cheeks. So there are basically 7 spots that we evaluate or try to screen out for having these anatomic restrictions.
That's interesting.
Mm-hmm. What symptoms should or could parents look for? Are there any telltale signs of a tongue tie, and can that differ based on the patient's age?
Yes, so when I I see a lot of newborns coming in, and we see a lot of older kids that we deal with speech and feeding problems, and they all seem to follow a progression, like a continuum of symptoms or functional problems. So when I do a consult, and I'll speak to you as if I'm doing a consult with a family or maybe a newborn who's coming in, and the first thing that was picked up is they're trying to breastfeed, and mom is having painful breastfeeding. And it's like something's wrong. Somebody may have identified, a tie, or they saw a lactation consultant or a feeding therapist and said, have this checked out because there seems to be something going on. So one of the earliest signs we'll see is a feeding problem, whether it's breast or bottle. That's one of the initial things. As a child seems to progress, the functional problems don't go away, but a lot of the kids learn to compensate or kind of learn to live with these things and using other muscles and other, whether they can use their whole body to try to feed and get through to try to gain the weight. So the next thing we'll usually see is when they transition onto solid foods, we'll see them maybe potentially struggle on solids. Many times they'll get labeled along the way, maybe by another healthcare provider, a pediatrician or somebody, as a picky eater. And, you'll do your assessment. We'll look at it. There's more than that going on.
Yep.
The next age group is when they start into the speech age groups, and so you're going step by step. And we see a lot of these kids follow these patterns. And whether next is either a delay or an articulation issue where they struggle with certain sounds, where they can't either get the tongue up to the roof of their mouth. It's not just sticking your tongue out of your mouth, and it's getting the tongue up to the palate behind the top teeth. I'm not going to go into all of the details that you guys look at from a functional standpoint, but we ask these general screening questions. Are they struggling with certain sounds? They seem receptively very bright and understanding everything, but their expressive component, there's often a mismatch. As the kids start to get older through toddlerhood or whatnot, sometimes they start to develop issues with tongue position, how they're breathing. We find that kids, when their tongue is restricted, it doesn't have the ability to rest on the roof of the mouth, which is where we kind of want that tongue to be. When it's not doing that, the tongue is what we term the natural palate expander. So we say your tongue and your lips are kind of nature's braces. And when they're not working that well, we start to see habits form. Maybe we'll start to see teeth spread out. Kids develop these tongue thrusting habits. At the same time, they're developing issues because they can't breathe through their nose properly. And that's usually secondary because the tongue is not resting on the roof of the mouth or the palate to help it flatten out and spread out. So your upper palate starts to get narrowed and it arches up higher. Your palate is the same thing as the floor of your nose. So if your palate is arching up into your nose, it makes it more difficult to breathe through your nose. A lot of these kids come in, they have these open mouth postures. They develop difficulty breathing through their nose. They're breathing through their mouths. They start snoring. There's a lot of issues that we see as a continuum. They're having potential speech issues, feeding issues, and it all kind of is pieces of the puzzle that start to make sense. And when you start to talk to a family, like, you're describing my child to a T. How did you know? And it's like, well, a lot of these kids follow patterns. So we'll see these different ages presenting with different things all the way up through adulthood. And we find that even as the kids get older, up through the adolescent age group, through up to adults, that tongue posture or position, because it actually is being held back and down sometimes, even closing your airway off, many people or kids start to develop what we call a forward head posture, to open their airway up, because that tongue is actually holding back and it's closing their airway off. So many times they'll start to develop that forward head posture, starts to affect neck issues, potential TMJ problems, neck back issues. So we see a lot of adults coming in with severe neck strain, TMJ problems, obstructive sleep apnea. So it's a continuum. These things basically affect the growth and development. There's been research looking at this that's been coming out, kind of verifying this. A lot of it's been coming out from Stanford University, UCLA, looking at this. There's a big pediatric dentist named Kevin Boyd, who's been very involved in the airway community and looking at this, what we call craniomaxillary respiratory complex, and how these tethers or inside the mouth affect that. So that's a long-winded response, but it kind of makes sense when you look at these kids.
No, absolutely, 100%. And I feel like we wind up going through those statements with our patients as well. We get that same affirmation that, yes, that's my child, that's my child. What does a parent do if they do see a professional that maybe doesn't agree that the tongue tie is short, or that they require frenectomy?
Yeah, so when we see families, like I was saying, we get this on a daily basis where a family either cancels an appointment or comes in, saying, well, my pediatrician said they're fine. They can stick their tongue out, they're gaining weight, they'll grow out of it, things will stretch. You hear all of these things, and each one of these myths has actually been debunked by research and science. So I my goal is to educate the families, and I say, there's nothing against your pediatrician, but sometimes we'll make a simple analogy. It's almost like having a plumber give you an opinion on a roof.
Yep.
Like that.
Yep.
Just because they're a pediatrician doesn't make them a specialist or really understanding, because the education is just not there. And I usually tell them, I said, the American Academy of Pediatrics gives guidelines for doctors looking at this stuff, and there's really no education about, tongue ties, what's normal feeding, what's normal speech, what's all of these things. They really go at looking at growth curves. They're looking at things from a different perspective. And when I really kind of hit that to them, many of them are like, oh yeah, that's what my pediatrician said. I'll say things like, but then on the flip side, I have many pediatricians or others that completely understand this stuff. Like, listen, I'm not a specialist. You need to go see a specialist. You need to see a therapist that deals with this stuff, and then, see a potential surgeon or somebody who deals with this. But that's rare. I want to say it's rare, but it's less than the other way. So I usually kind of just educate the families as best as I can. In some instances, I'll point them towards research. I have on occasion saying, can you email me some articles or literature? And I gladly do that. And I'm involved in a lot of research in this area, in these areas, and we publish, and we kind of just really work on education. And it's not about selling a procedure. It's not about saying this or that. We just kind of give them the whole consult, the whole spiel, and make sure they're educated and let them be informed. And that's one of the things we get upset, when we have, a healthcare provider or pediatrician actually steering somebody away from actually getting informed and getting educated on something, and just saying, don't do it, don't do this, or don't do that. And you say, well, you should let, a family make an informed decision. And, it's kind of frustrating that way.
Is there any protocol that pediatricians, I know this is a little off the cuff, this question, but is there any protocol that pediatricians are using? We check growth milestones, we check head circumference, weight. Is there anything that's put into place for checking tethered oral tissue?
Nothing. Zero.
Which is alarming.
It's very frustrating. Because when you go through medical school, if you go through pediatric residency or whatnot, there's very little, given even on, normal feeding. Right. What is normal infant feeding? What's normal toddler feeding? What is normal, speech? What is normal oral facial growth and development? No education on it. And it's not to say that, you can get the education. You have to just, look for it and get it afterwards, but it's there. You just have to seek it out.
Got it. You're up to.
One question we get often is a tongue tie hereditary? Or
Yes and no. There definitely are types of tongue ties, and there are some that do run in families, or lip ties or other tethers in the mouth. Um, there are some, especially the ones that tend to be more towards the tip of the tongue that everybody can kind of see across the room, have a little bit more of a male predilection. Sometimes you see that run more on the male side of the family, and we'll often find when we speak to families, like you start describing these things, like, oh yeah, the dad had it, the grandfather had it. That's when you
Yeah.
start hearing stories, or this cousin had it, and so a lot of them do run in families that way.
Absolutely. Of course, a lot of parents are always concerned about the initial consultation visit when we're referring for a frenectomy or for a frenum, or concerns regarding a shortened frenum. And then what happens and what type of procedure? Is it painful? What does it entail?
Right. So when somebody comes, say, into my office for a consult, we're strictly talking about the consult, but we always will build in time just in case it's able to be done. We have a green light from you guys that it could be done at that time. But we spend the majority of time is talking, just like we're talking here. We look, we show, is a lot of show and tell, showing the parents what we're looking at, and actually running through some screening things. Can your child, lift the tongue up to the roof of the mouth? Can they do it? How high can they get that tongue up to the roof of the mouth with the mouth open, suctioning, and running through some basic things. And we'll show them, this is what the frenum is. This is why it's restricted. This is where it's attaching. And this is why it is impacting the functional aspects. And then we talk about the procedure itself. The procedure itself, from a surgical standpoint, is a pretty, straightforward procedure, pretty quick. And I can show, some videos even towards the end about this, and I'll run through some pictures. But the actual procedure is not very painful. We do make sure, pain management is upmost, so if we're dealing with infants, we still numb infants up, so the newborns that are dealing with, feeding issues, we numb them up, but just not with shots. I use just a topical numbing jelly. Once I start to get more towards the toddler age group, maybe it's, 3, 4, 5 years old, not only will we numb these areas up with a numbing jelly, but I do give a small injection. Like, I hate to use this shot word, but when I'm describing it to the kids who can understand, if we can walk and talk them through the process, which many can, we say we're going to squirt some medicine in there with a little special straw after they numb up and the procedure itself is not painful, and they shouldn't feel any pain when we're doing the procedure. When we get into that toddler age group, maybe 3, 4, 5 years old, when they have a lot of anxiety or potentially can't hold still, sometimes we will add maybe a light sedative to the mix, not a general anesthetic.
Okay.
We don't do these procedures under general anesthesia, but sometimes we'll offer a medication called Midazolam, which is like a Valium type of medication, which oftentimes is given by drink. Sometimes if we have, maybe sometimes we even get a big 2-year-olds or 3 or 4-year-olds, sometimes we'll give a little shot in the bottom. And what it does, it doesn't knock them out completely, but it makes them kind of drunk, and they, kind of goofy and relaxed. But the thing about that is it gives them amnesia. So they don't remember the actual procedure. That's a nice thing, especially because afterwards we have to go and do some stretching exercises at home. So we don't want them to be traumatized about going into the mouth to do some exercises. Afterwards, the majority of the kids really don't complain much of pain. It feels a little sore, but they don't seem to have much pain, and they usually eat right away. There's no restrictions in their diet from our standpoint. So the babies, we get back on the breast or bottle immediately. The older kids, we get them on their diet, whatever they've been dealing with, and then hand them back over to you, to work on, feeding and speech. But it's a pretty brisk, very fast recovery.
I was lucky enough to come in and watch you perform some frenectomies, and it was just amazing to see it from start to finish. But one of the things I remember is that, especially those that were having difficulty with breastfeeding, after you performed the procedure, they went into another room and attempted again. And then talk us through what that would typically look like, and what are they looking for, and what would you do?
Yeah, so what we're looking for, a lot of the moms that are coming in having breastfeeding difficulties, the vast majority are having painful feeding. And reason being is when there's a tongue tie present, they don't have the ability for the tongue to really move in this really organized wave-like motion. And what happens as a result, they can't draw the nipple deep into the mouth. So the nipple stays more shallow, and the babies tend to chomp, and they're kind of all over the place. If they have a lip tie, it often keeps the lip more curled in or tucked in and tight, doesn't let the lip flange and form a good seal. As a secondary result, that can break the latch or the seal. We do find a lot of babies suck and swallow lots of air. They can get a secondary, colicky symptoms, refluxy symptoms, things like that. But one of the immediate changes that we often see, not always, is that there's a reduction in pain on feeding. And we see that immediately afterwards. So as soon as a procedure is done, with a breastfeeding mom, we'll take them into the next room, get them on the breast. I do have, my staff are certified lactation counselors, so they help with latching and positioning. And many of the moms will say, "Oh, I feel it difference right away. It's deeper, it's not as pinchy." But we do the same with the bottles. We get them feeding on bottles immediately. So, we're looking for changes, less choppiness, and I can't, talk about the functional components, but we see differences. See the ability for the babies or the young ones to open their mouths, their gape immediately changes. Many parents will say, "I see a change in my baby's face. They seem less tense. They seem less tight." So there's a lot of things that we see immediately. And then when they're in there, so in that you're talking about the babies, the toddlers will again go into the next room. Everybody settles down. Then we have a whole, big session on what to do at home and go over all that.
Okay.
Perfect. Wonderful.
Yeah.
All right. Is there anything that you have to do or that you do that you find helpful to keep the child still?
Yeah. Again, depending on the age, depending on, anxiety levels and, what's going on, there's different means or different modalities that we have. So a baby or an infant, that we just swaddle them up. We just are kind of like a little, burrito. And we swallow them up. But we do that with the toddlers too. We do that, many times with the toddlers. Sometimes we'll have them sit on a parent's lap, depending on the size, depending on the parent's willingness to do something like that. Sometimes we'll swallow them up like a burrito. And I usually have, on average, like 1 to 2 assistants with me. So it's not like 4 or 5 people holding a child down, but it's usually 1 to 2 assistants helping just, stabilize a head maybe. I will say that we get very good success in a lot of these kids just sitting still. It's amazing. I'm always amazed at the 4-year-olds that come in and we can walk and talk them through this. Not everybody. And there's the 3-year-olds and the 2-year-olds. They need to be held still. Or maybe,
most of the time, it's the parents, right, that need
absolutely.
that sedative.
Listen, I have 3 kids. I know exactly what it's like, and I remember even taking my first, child for blood tests.
Yeah.
I was a nervous wreck and having to hold my child still, and I was a doctor at the time, so I totally understand. We're treating the parents more than the kids, 100%.
Absolutely.
Half the time they're asking, do you have a bar here too? And it's like, or if they can have some of the sedative medication. So there's a lot of hand holding on everybody's part.
Absolutely. Does your approach vary if there's a child with special needs or an individual with special needs coming in that maybe cannot understand cognitively what is being done?
Yeah, that we see a lot of the special needs population, and it's a very near and dear aspect, because I actually trained in that in dental school. We had a big special needs program where I did my residency, huge special needs program, and we deal with that all day long. And, I get a lot of input from the parents, how should I be approaching your child? Let me know, because I need to make sure I don't want to, take it down too low. I don't want to be too, so I get most of the input from the parents or from you guys, the therapists, because you have dealt with these kids specifically on what works best. Okay. So with all of this stuff, there's no one right way, and there is an art to a lot of how we deal with each of the kids, and each of the families, especially when we're dealing with the special needs population.
Okay. What is the difference between clipping or cutting and laser? Is there a difference in recovery? Is there research that supports one over the other?
Yeah, the simple answer is, I think the biggest difference is in the provider who's doing, because My mentor in this whole area was a scissor provider, and she did beautiful releases with scissors. At the time, I was using lasers in my practice, and we were working back and forth, and she's like, well, I think the lasers are working better for some of these deeper posterior tongue ties. We're getting less bleeding.
Okay.
So the biggest difference we find between the two modalities, when you're talking about scissors or scalpels and things like that, they tend to bleed more. When you're using a laser, and it depends on the type of laser, you get less bleeding. Maybe it's a little bit of a faster, procedure. Not always, but in my own experience, and I've been using lasers going on 21 years this year, specifically carbon dioxide laser, we get less bleeding. We get a more precise dissection. We are able to get, maybe potentially deeper with these releases without the bleeding. We find, in my own experience, I do a lot of revisions or a lot of redos from other providers, because we find that a lot of times if they're snipping, they'll say it's just going to be a quick snip. That's not. There's more to it than just a quick snip, because we find that a lot of times if they do a quick snip, they're not doing it completely, and we find if they're going to do it completely, it tends to cause a lot more bleeding. And the parents I prefer to do the laser because of those issues. There's some research now coming out looking at these things side by side, because it's poorly studied.
Okay.
But when you really kind of look worldwide at the docs and the people who do the most, volume of these procedures, doing research, we use lasers, and the majority of them are either what we call carbon dioxide lasers or maybe erbium lasers. Those are types of lasers that don't touch the skin or don't touch. There's a lot of people using something called the diode laser, and that's that causes a lot. It's almost like a cautery, or what we call a hot glass tip. It's not a true laser, because it actually causes more thermal injury, more pain for people afterwards, and more scarring, or what we call reattachment. So it's kind of, if you're asking your provider, it's kind of good to know what type of laser they're doing. There's a lot of questions you can ask about that. How long have they been doing these procedures? How many do they do a day or a week? What are their, post-op instructions, or, wound management care and guidelines, or pain management, and their what we call reattachment rates. So.
Do you find there's more infection or scar tissue when there's more bleeding, or is there really no correlation?
There's really no correlation.
Okay.
In this actual procedure, either technique, risk of infection is really next to zero. In my own practice, I've not had one, and I know, I'm going to speak for a couple of colleagues, but there's another colleague up in Albany, Dr. Kotlow, who's another pioneer, and he's not seen an infection in maybe close to 30 years of doing this with lasers. But even if you look worldwide, there are reports of infections. We don't know what was going on, because it seems that's an extremely rare event, either way, scissor or laser.
I feel like in this day and age, that's a question that a lot of people are concerned about and asking. So I think that's a really important point that you just.
When I actually talk about risks, of the procedure, risk versus benefit, we say, well, when we look at this side by side, the risks of keeping the ties long term seems to outweigh the risk of the procedure. So in medicine, we're always looking at this risk versus benefit. So the real issues, and it's not a true risk, is but that they can heal back together or potentially scar a little bit. So that's why having this what we call active wound management or stretching protocols are very important, and making sure you follow up not only with me but with you guys to make sure we're getting the best results there. But we're not really near any nerves. We're not near any major blood vessels. As long as it's done right and you're doing it with an experienced provider, it's very minimal risk. Not to say that things don't happen. In my own experience, I haven't had them, but I've seen issues, and I've gotten referrals from people that didn't really know what they were doing and potentially cutting in the wrong spots or whatnot. So the risk can go up.
Yes.
What if a parent chooses not to do the procedure? Are there some long-term effects there?
Right. So when I consult with the family and said, this is what I see, this is what's going on there, by no means do you have to do anything. This is elective. Unless we're getting a child, on occasion we get a child that completely can't eat. They're, losing weight. They're ready to get a tube, and, we say it's a little more pressing.
Yes.
But we say, if you don't do it, you're just more likely to have other issues going forward. So kind of we describe those issues, you know, in sequence as the kids grow and develop. And when I go back to risk versus benefit, I say, well, the risk is a little bit higher of having further issues as they get older that sometimes become more difficult to unravel versus catching them earlier and being proactive and preventive. So I say, you know, a small amount of an intervention is a lot more prevention for these kids long term.
Absolutely. Do you feel that myofunctional therapy plays a role, and those stretching exercises play a role in the patient's overall success long term?
100%. I mean, there's no question about it. And there's research now that's been coming out validating this. And we
Finally.
look at this. Yeah.
We've been waiting, you know?
Yeah, it's you know, all of this speech and myofunctional people been waiting, and it's been coming out. It's been validated now, you know, by other professionals, and looking at, you know, not only doing it, but doing it in a sequence where you're doing some oral myofunctional therapy, speech therapy first, and then doing a release, and then continuing that. And I've always lectured about having this, I called it the sandwich technique, where the surgery's in the middle somewhere, and you're doing some therapy, you know, surgery. Not to say on some instances we have to do the surgery first in order and get to the next levels, but working as a team with a speech or myofunctional therapist is, you know, it has to be done, and just really get the best result.
Yes.
Do you have a recommendation on time frame, like how long you want them to see a myofunctional therapist before the procedure?
I don't have specific guidelines. I kind of leave it up to you to feel when you know, the child is ready, you know. So it's you know, in the 20-something years of doing it, I had so many kids that would come in without any therapy, or before or after, you know, and those kids would flounder. And again, this is all, it's a journey. We're all still kind of learning this together. And that's the whole thing. There's an ENT up at Yale, Dr. Karras, who says, you know, quoting him, is like, you know, we're like on an airplane ride together. So all doing this, you know, in this whole area of tethered oral tissues and understanding this stuff. So how much therapy is the right amount beforehand? How much is right amount afterwards? There's no one right answer, because each child and each situation is different. So I can say, you know, if a family comes into me, it's like, well, Janine or Toniann, they're going to make that decision when they feel you're ready to come in for this. You give us the green light, you make the appointment, you come in, then I get you back over there, you know, to continue.
How soon after do you think they can reconvene therapy after a procedure? I
say the sooner the better. In my experience, you know, preferably, you know, that next day, you know, if they can. I like them to kind of, we liken it to physical therapy, you know, after an orthopedic injury. You want to get things kind of mobilized, or, you know, you get the hip replacements up walking, that, you know, same or next day. So you want to get these things functioning right away.
Absolutely.
What does the aftercare for a parent look like? What can they expect?
So aftercare is variable depending on the age and what we're releasing. But there is a period, and we call it aftercare. And the biggest thing everybody talks about is stretching exercises, you know, and, you know, when we do lasers, the vast majority of times we're leaving an open wound. Not always. In some instances, we do stitch and whatnot. But a lot of people like lasers because it can be very quick that way and lessen the need for an anesthetic or anything like that. So many times we keep an open wound. The goal of what we call aftercare is to keep that wound as open as long as we can, so it doesn't just shrink down and what we call reattach or heal back to itself. So if we're doing a baby, they're the easiest because you can just get in there and kind of have your way and just do these stretches and whatnot. When we start to get towards the toddler age group, they're the 2, 3, or 4-year-olds that have teeth and maybe a little more challenging, we sometimes give them tools to work with at home to do these stretches. Yes. On average, we're doing stretches maybe 5 times a day for the first 2 weeks, and then I'll start to taper off over the next couple of weeks. And again, they're a little bit variable, but the whole goal, you know, is to really stretch the wounds open. And they're not painful. When I do older kids who can really tell us what it feels like, it's annoying. You know, the little ones, they don't want you in the mouth, so they're going to scream, they're going to kick. So we try to, you know, the ones that come in well prepared, having some oral myofunctional work, having some work done in the mouths, do much better afterwards.
should they ever complain of pain during those exercises post-op in that aftercare period?
They'll complain, and again, we look at, the older kids and the adults who really can kind of objectively tell us, is this really painful?
Yes.
Is it a little sore? Or
Yes.
are they being overly dramatic or whatnot? Because we'll get a lot of parents like, I'm hurting them. They're going so crazy. It's like, it's really not painful. We do have to muscle through it a little bit. In the event that a parent can't do it, and they're local enough, I say, just come in to me, see me weekly. I'll do a stretch, make sure nothing's reattaching, and we try to do it that way. And again, we have, we're dealing with everybody, so everybody's different. And
do you see reattachment occur more often with certain age groups?
I see reattachment occurring more. It's not so much maybe in the age groups where the parents feel they can't get stretches done. And that could be like the 2 to 3 year old, the toddlers. We're potentially seeing a little bit less. I started using some surgical glue in the wounds, and we're seeing a little bit slower healing instead of stitches. So we're seeing that. We see that, many babies do reattach because they're just kind of sitting there and not moving anything. And
Yes.
if a parent's not getting in there to do the stretches actively, they're a little more apt to reattach. I find the older the kids, they start really kind of exploring and moving things around, and they're a little bit less likely to reattach.
Definitely. They do seem to be happy that they can lick a lollipop or lick an ice cream cone. Just some of the things that they didn't really
like,
put
wow,
in.
it's
Yes. Yep. Absolutely.
Yeah.
Absolutely. I know you wanted to share some videos and some slides with us.
Let me see. I'm going to pop up share screen here. So, I can run through some of these slides. Can you see the slides okay?
Yep. Yes,
Plus,
absolutely.
kind of gives you some definitions here. What is a tongue tie? There's technical definitions. Is the embryological remnant of the tissue in the midline of the undersurface of the tongue and the floor of the mouth. So it's that little string. But you can have ties. You can have them on the upper lip. You can have them on the lower lip. You can have them in the cheeks, which we call buccal. So the top and bottom. So there's a total of 7 spots that we look for these, what we call ties. But let me...
Dr. Siegel, can I ask you a question?
Yes.
A lot of times when we identify a lip tie, depending on the provider, they either want it addressed pre-orthodonture or post-orthodonture. Is there a rationale as to, or what a way to do or an approach that's better?
So that, when we look at that, and that's the way we were all taught in dental school, is that you do it after braces are on. And there's been a change now in timing. And it comes out of, there's a textbook that has one line saying that they're going to form scar tissue if you do it beforehand. And that's where that whole thing came from, one line without any science or research. And it's been across the board that people say that. So there's actually it's not out in publication yet, but I think it was submitted. There was a big series on doing lip ties beforehand. I don't know if you can see the picture on here.
Yes.
So this is just a, child that had a lip tie, difficulty keeping teeth clean, some speech issues. It's going right in between the teeth. And we did the lip tie before any braces, and you can actually see changes very quickly. Teeth starting to align, and not only the nice wound healing, but teeth start to align better once these are released. So there's across the board, when you're dealing with specialists in this area, we're finding that pre-orthodontic release of the ties and myofunctional therapy is lessening the need for a lot of orthodontic intervention. And that's what we term nature's braces, are your lips and your tongue. So you guys are working on these muscles to help them, the lips kind of help, align the teeth from the outside, and the tongue and tongue position helping mold the palate and the teeth from the inside. So we're starting to see these changes.
It's good to know. And I think it's an important question that's asked often. And I think you're right, misunderstood everybody's understanding of that. So I'm glad we're telling our patients the right thing, and obviously they're getting to make their own decisions, but I'm glad we're at least giving them the intelligence and that background information so that they can make an educated decision.
Exactly. And that's what we talk about. Let me just show, a couple of things about, tongue ties. I'll show you without teeth and I'll show you with teeth, but this is Dr. Kotlow's classification system that he uses. I kind of classify them. The one I use is this system. She was my mentor, Dr. Carrillos. She was a pediatric surgeon, and it's a very similar classification system. But what we're looking at is, from the top left here, we talk about anterior ties versus posterior ties. And we lump them into two broad categories. Anterior ties, you hear these terms thrown about all the time, where you go on social media and people are talking about posterior tongue ties and anterior, So it's a simple term. Anterior is the ones that you can see close to the tip of the tongue. As that attachment goes further back from the tip of the tongue, when it's like more than midway from the tip of the tongue, maybe to the floor of the mouth or the base, we call it posterior. So on these bottom two slides or pictures here, you'll see what we term more posterior. So I really don't get too hung up in these classifications. We're looking at function and symptoms. Sometimes we see these kids that look really tied, actually sometimes function better than the ones that don't look as tied. And it really has to do with the ability to elevate the tongue and get up to the roof of the mouth.
Probably compensatory strategies that they're using to support that muscle movement, I'm sure.
100%. So some of these kids, and you look at how it's affecting. Many times these ties are attaching behind the teeth. They start to pull teeth in. They're pulling on gums and gingiva and things like that. So from a dental standpoint, we start to look at things as well, as well as the function and whatnot. So you can kind of see some pictures of what different types of ties may look like. There's a lot of different types of ties. And, when we look at lips, we look at where these things are attaching, and there's all different points of attachment. The simple tests we'll do for like a lip tie is lift the lip to the nose. And if you, like you see on these pictures, if you see that the gums are starting to turn white, or what we call blanching, we'll say, well, that's basically what we consider the criteria to say it's a tie versus a normal frenulum. A normal frenulum should be stretchy and pink, no tightness or anything like that. You can kind of see where these things are inserting. On the left-hand side, maybe you might see it in an adult, the impact of these ties long-term is it starts to pull the gums away from the teeth and cause gum recession.
Can a lip tie actually impact the ability to close the lips, or can it pull that upper lip upward and not allow for that closed mouth posture?
And we depend on you to tell us. I know this child can't get full lip closure. Those restrictions, whether it's the lips or the cheeks, are preventing from closing the lips fully. And that could be part of the treatment plan, to release these ties, to work on lip closure, releasing the tongue. If it's a tongue thrusting issue, to get that tongue up to the roof of the mouth. So it's a domino effect.
It's a domino effect.
It really is. This whole thing, what we call buccal ties or cheek ties, if you can see, I don't know if you can make it out, but there's like these little webs on the sides here. And that's, they cause issues with cheek function, lip function. I leave it up to you to tell me if it's impacting the function. And, we can say, oh, this is the anatomy. We see it might be impacting growth and development of the jaws, the teeth, and the face. And then we're relying upon, the speech and oral myofunctional therapist, feeding therapist, to let us know if it's impacting function.
Absolutely. I definitely feel like the buccal ties aren't assessed as much.
No.
And when we do make referrals, even a lip tie, I feel like most of the times when we make a referral, and if they're not seeing you, Dr. Siegel, they're more looking at that lingual frenum. But we've also even had feedback saying that as whomever they want to will not do a posterior frenectomy with a laser. That's not something they're comfortable with. But you use your laser for all types of ties.
All types of ties. We do something called, especially in the adults or whatnot, we do something called the deep lingual frenuloplasty, which we're getting through muscles. We're going, pretty deep, and maybe you get a sense here, and you can kind of see. We kind of get deep. I'm not getting, too involved here, but we're down into muscle areas here. We're looking to get that tongue fully elevated. Many times I won't stitch, but sometimes we do stitch, and there's some factors that go into it. Sometimes if I'm going to stitch and we tighten things back up, I don't want to stitch, and we'll work on stretching. But sometimes if the wound is too big or we're going to get, maybe too much pain, sometimes we do stitch. So there's not one right way to do it that way.
Can there ever be a detriment to doing a release? Could there ever be too much mobility or?
There are instances, and we've had that, where a child, may have more disorganization of feeding. So I don't say this is, the be all and end all, and we choose our patients carefully.
Okay.
And make sure they're fully prepared, because on occasion, I've had this in my own practice where we had a baby that may have been feeding okay, and all of a sudden we did a release and they're not feeding as good. Because their compensation or compensatory strategies are gone. And we weren't as prepared. But I find the ones that we're really prepared with, and if they're coming in, where we're working as a team and we're all in agreement saying, yeah, we're going to see that this patient's most likely going to benefit. I'd say usually the worst case scenarios that we're getting no change, but I typically don't see anything getting worse. The vast majority are improving.
Good. Excellent. Oh, yeah, that's good to see.
Let me see. I have a quick video too of like an older child, I think, with a
that'd be great
procedure. Let me pull it up. And you might want to mute it too, but I think it's okay. I don't think it's
nothing inappropriate.
Yeah. I don't know how well it's coming up there.
You can see.
It's a lip tie. And the patient's already numbed up. But if I were to do this with a scissor, it's bleeding all over the place. It's a big, bloody mess. You get a little bleeding. Lasers don't mean you don't get any bleeding at all, but it's a lot less. It's a little bright there, but you can kind of get the sense.
So interesting, right?
Big difference that quick.
What would you say the time is?
The laser basically is just vaporized. It's not burning tissue, but it's vaporizing the tissue, so it's kind of just going up, in the air. And that pen or the laser is not actually touching, the mucosa or the skin. It's what we call optical contact. So it's an invisible ray of light, focused light, that's actually, getting into the area to vaporize the tissue.
How long would the procedure actually take? I mean, when I watched them,
we're slowing this down for the video. So the actual procedure is, I usually say if I'm doing a lip and a tongue tie in a child or multiple ties, it's about 30 seconds.
Wow.
Once we get in there, it's pretty quick. We don't waste any time. And the parents are usually like, that's it?
Right.
I longer to talk about it than to do it.
That's what I usually tell them. When watching it, I said it takes longer for Dr. Siegel to prep everything than it does for the procedure itself.
This is a tongue tie in a speech age child too. I don't know if you can see well there.
Yep. Mm-hmm.
So we're basically getting down to the muscle layers. Most of the times I don't go through muscle. Mm-hmm. On occasion we do if we need to really, find that it's still restricted. Mm-hmm. But you can actually feel the tethers release. You can feel the tongue pop. You can feel, and many times the patients will feel that too. It's like, I felt that. I felt something pop and release. And they say it felt good or it felt straight. You can actually feel it through the body. The adults and the older kids can tell us. You're feeling, there's a sense of release through the body.
Yes, they're no longer holding that tension, I'm sure. It makes a big difference.
There's been a lot of research looking at the connections, and I'll pull up, there's a slide here showing the body connection between, the tongue ties and what we call the fascia system, of the body.
How often do you see them post-op, Dr. Siegel?
So if they can come in weekly, many times they can't really get back in to see me, but they at least will send me pictures weekly. for at least the first month.
Okay.
Or any time in between, if they have any questions or concerns, they all the families get my cell phone to be in touch. We try to track them at least, weekly for the first month, hopefully longer if they can. So many of them will start to, fall off. But there's been a lot of research coming out from the physical therapy community, occupational therapy community, looking at the connections, what we call fascia. And this is a dissection, what we call the deep front line of fascia. And fascia is this connective tissue that's underneath our skin and underneath these areas that kind of connects everything together. And it's an area where a lot of people get pain and things like that, muscle pain and whatnot. But we have found a lot of kind of anecdotal things that we were doing these releases, especially in older kids and adults. It was like, my whole body feels looser. My neck is looser. My head, there's a lot less tension. And the research has shown that, if you look on the top, the tongue here is actually connected all the way down to your toes by this front, we call deep front line of fascia. So when we release the tie up here, it kind of just lets everything else drop and the tension is released. So a lot of times we wind up working with other therapists, what we call a body worker, like a physical therapist, occupational therapist, chiropractor, craniosacral therapist, in conjunction. And this is why, because all of these things are connected, not just by the compensations, but by this actual physical anatomy.
It's a whole team approach when it comes
Really
to
is.
the tether tissue.
That's what we always write here.
Yep. Yep. Absolutely.
So it's a team, and when we work outside of the team and you're kind of working by yourself, you're not going to get a good result. You're not going to get the optimal result anyway.
We see the same thing.
Yes.
Yeah.
Thank you so much. I know we asked you some questions off the cuff today, but I appreciate you so much being here and giving us this education and giving any of our listeners and watchers this education, as I really do think it's something that there's so many misnomers and so many things that are misunderstood that I think this is really going to be something they can use as a reference, especially if they have some questions.
Perfect.
Thank you so much, and hopefully we'll see each other soon.
Sounds good. You guys are great.
Take care, you too. Thank you, you too. Take care.
Bye.
Bye.
Bye-bye.